A blood test shows moderate renal failure. Letter of referral. Dear Dr. Mr. Peter Ward, aged 38 years. This garage mechanic came to see me with a vague history of fatigue a week ago. He was hypertensive, 160/104 mmHg. His blood tests showed Na 134 mol/L, K 4.8 mol/L, urea 21 mol/L, creatinine 370 mol/L, hemoglobin 10.1 g/dl, mean cell volume, MCV, 89 FL, white blood cell count, WBC, 4.2 x 109/L and platelets 254 x 109/L. Please consider investigation of his stage 4 chronic kidney disease and advise concerning further management. Yours sincerely. Introduction. The emphasis in the history-taking station of PACES is clearly on conditions that present to medical outpatient clinics, but how do you know that this is chronic renal failure? The answer is that you cannot be sure from the information provided. This could be acute renal failure that is potentially reversible, and you must recognize this in your approach to, and discussion of, the case. How will you establish whether the renal failure is acute or chronic? Further values of creatinine are required. Any previous blood tests would be useful, and urgently obtain a current creatinine sample to check that renal function is not deteriorating rapidly. Renal ultrasound is very important. Reduced renal size would prove that there is chronic kidney disease, but if this is the case, there may still be an element of acute on chronic renal failure. NB. Take an exhaustive approach before concluding that renal failure is chronic. History of the presenting problem. How long has the patient had renal failure? Renal failure does not produce dramatic symptoms. Ask specifically about the following. Energy. Many patients with advanced renal failure simply notice that they are exhausted all the time. Concentration. Uremia causes mental dulling. Breathing. Anemia may cause breathlessness on exertion, and fluid retention can cause pulmonary edema. Appetite, nausea, or vomiting. Uremia causes anorexia and, when advanced, nausea and vomiting. Nocturia. The normal kidneys elaborate concentrated urine at night. They cannot do this when they fail, and this leads to nocturia, a significant symptom in a young man or woman, prostatism being a much more common cause in older men. Itching, a symptom of uremia. How long has the patient had a renal problem? Are there any clues from the past? Take a detailed history of any contact with medical services. Approach this from several angles by asking the following questions. Have you ever had kidney disease or swelled up in the past? Has anyone ever taken your BP before and told you it was high? Have you ever had your urine tested? Have you ever had a medical for work or insurance purposes? Have you ever had a blood test or had blood taken? Knowing that the creatinine was normal or abnormal 3 months ago would be a crucial piece of information. What is the cause of renal failure? Explore all avenues that might suggest a diagnosis or etiological factor. In particular, note the following. Recent illnesses such as diarrhea or upper respiratory tract infection, which in retrospect may have heralded the start of the illness, would favor an acute etiology. Multi-system disease. Any previous rashes, painful or swollen joints, eye pain, hemoptysis, numbness, weakness, or tingling may point to a systemic inflammatory illness such as vasculitis. Urinary tract symptoms. Childhood recurrent infections or enuresis suggest reflux nephropathy. Recurrent hematuria associated with upper respiratory tract infections could point to IgA nephropathy. Has the patient had urinary stones? Drug history. This should include over-the-counter medications, illicit drugs, and traditional and herbal remedies, because all of these have been known to cause renal failure. Family history of kidney disease or of deafness. Plan for investigation and management. Investigations. The key issue is to determine whether the renal failure is acute or chronic, which can only reliably be done on the basis of previous measurements of renal function or ultrasonographic demonstration of small kidneys, Fig. 4. Certain chronic renal failure. If renal failure is chronic, then the investigations shown in Table 3 are required. Further pursuit of a specific diagnosis is likely to have a poor yield, make little difference in terms of subsequent management and potentially risk complications. In particular, a renal biopsy would not be useful. NB. A renal biopsy is contraindicated in patients with small kidneys. It is technically difficult, has a high complication rate, and the pathological findings are nonspecific. Uncertain diagnosis. In some cases it is not certain whether renal failure is acute or chronic. It is then necessary to carry out tests to exclude potentially reversible diagnoses, Table 4, and in some cases a renal biopsy may be indicated even if the kidneys are reduced in size. If there is any doubt about the findings on ultrasonography or if they seem at odds with the clinical setting, ask an experienced radiologist to repeat the study or consider CT, which is less operator dependent, Fig. 5. Management. There is no specific treatment for chronic renal failure, but particularly note the following. Angiotensin-converting enzyme inhibitors and angiotensin receptor antagonists slow the progression of chronic renal disease, but remember to check serum creatinine 7 to 10 days after initiating treatment to ensure there is no acute deterioration. A rise of up to 20% can be tolerated, but a more substantial rise suggests the possibility of renal arterial disease and should lead to the drug being stopped and consideration given to imaging the renal vessels. Also remember that these drugs may exacerbate the common tendency to hyperkalemia in those with advanced chronic kidney disease. Cardiovascular morbidity and mortality are extremely high in patients with renal impairment. All require a full cardiovascular risk assessment, followed by attempts to deal with reversible factors such as smoking, hypertension, and lipids. Treatment of anemia, usually with erythropoietin. Treatment of hyperparathyroidism. Dietary advice may be appropriate and is most commonly to restrict potassium intake. Further discussion. Telling a patient that he or she has chronic renal failure and will need long-term renal replacement therapy can be devastating. The reaction is often similar to that seen in bereavement, with progression through shock, grief, and denial before reaching acceptance. Accurate information and continued support are essential and best provided by a team that includes doctors, dietitians, and specialist nurses.